Welcome to my presentation on the neuroscience and neurobiology of opioid dependence in the United States. We have special guest Clementine here with us today for the occasion. Let's get started. The rationale for this project. So, in Dr. Benito's class, we studied different drugs and their interaction in different users and patients. And at the same time, I saw an article on the New York Times. I don't remember the exact article, but I remember it talking about the overuse of prescription drugs, specifically in high school students, and the use of opioids, sadly. And upon doing research, I found out that pharmaceutical companies in the late 1990s dispelled any fears from the community that patients would become addicted to pain relievers called opioids. And as a result, opioids were prescribed at increasingly high rates by healthcare providers, and this increase in prescribing the drug led to a spreading misuse before it became known that these pills could be actually highly addictive. Also, the HHS, Human and Health Services, stated that opioid use was a public health crisis, and as you can see by this data here, 70,630 people died from a drug overdose in 2019. 1.6 million people had an opioid use disorder. 745,000 people use heroin in the past year. You could see just the high numbers of drug usage in the United States. It's quite surprising. It's really sad stuff. So as I work through this slide, please reference this diagram on the left-hand side. The mesolimbic midbrain reward system is one of the brain circuits that is activated by opioids. The system generates signals in the VTA, this area here, the ventricle tegmental area part of the brain, and this results in the release of the chemical dopamine, DA, in the nucleus accumbens, so here, NAC, this part of the brain, this release of dopamine in the NAC causes feelings of pleasure, and other areas of the brain create long-lasting memory of these good feelings when and why and in what environment they occurred in as well is noted. These memories are called conditional associations, and this is what makes a user crave drugs when the abuser crosses paths with a person they did drugs with or a place where they did these drugs, and yeah, that's how they keep relapsing and craving it. So now we're going to talk about the neuromechanistic effects of opioids, which is the basis of dependence and withdrawal. So the locus coeruleus, LC, is an area of the brain that is critically involved in the production of opioid dependence and withdrawal. So the diagrams here show how opioid drugs affect processes in the LC that control the release of noradrenaline, NA, a brain chemical that stimulates wakefulness, muscle tone, respiration, among many other functions. So the slide on the left here, normally natural opiate-like chemicals produced by the body link to mu opioid receptors on the surface of the neurons. So this linkage activates an enzyme that converts a chemical called adenosine triphosphate, ATP, into another chemical called cyclic adenosine monophosphate, which is CAMP, which in turn triggers the release of NA. Prior to the initiation of opioid drug abuse, the neuron produces enough NA to maintain normal levels of alertness, muscle tone, and respiration. But now we'll see that the slide on the right, when heroin or another opioid like drug links to the mu opioid receptors, it inhibits the enzyme that converts ATP to CAMP. So as a result, less CAMP is produced, less NA is released, and the alertness, muscle tone, and respiration drop. And the acute opioid effects of sedation, shallow breathing, etc., they appear. Now that I've explained the neurobiology and the mechanistic pathways, I would like to talk about how we can provide pharmacological interventions and treatment for opioid dependence. Because in my research, I was surprised to find out that the medications most commonly used to treat opioid abuse attach to the brain cells opioid receptors like the addictive opioids themselves. So among several drugs I found on the Substance Abuse and Mental Health Services Administration, due to interest of time, I'm presenting just two of the most used sources of interventions in a pharmacological sense. Methadone. Methadone is a long-acting opioid medication. So unlike morphine, heroin, oxycodone, and other addictive opioids that remain in the brain and body for only a short time, aka bad drugs, methadone has effects that last for days. So it's a good drug. So methadone causes dependence, but because of its steadier influence on the mu opioid receptors, it produces minimal tolerance and alleviates craving and compulsive drug use. Here, the second intervention drug I would like to talk about is naloxone. It is a medication designed to rapidly reverse opioid overdoses. These drugs are needed in acute cases like the case of Miles McEntee, who died of a heroin overdose last June in the Austin apartment he shared with his younger sister. Kelly McEntee wonders if her son might still be alive if his sister Taylor had a dose of naloxone in the medicine cabinet, which goes to show you how powerful this treatment can really be. The medication can be given by intranasal spray into the nose, intramuscular, subcutaneous under the skin, or intravenous as an injection. I want to talk a little bit about the success towards the opioid epidemic because I don't want to paint a gloomy picture for you. There's hope. Currently, $9 billion in grants from Human Health Services is being provided to states, tribes, and local communities to fight the opioid crisis. And as far as recovery, nearly 14,000 plus substance abuse facilities in the U.S. have grown to provide relief and psychological and physiological interventions such as talk therapy and counseling, which is wonderful. 1.27 million Americans are now receiving medical assistance and medication-assisted treatment with methadone and, as we discussed, naloxone. And finally, all this work has shown a 4.1% decline in drug overdose deaths in the United States. 4.1%, it may not seem like a large number, but proportionally speaking, it adds up because there are a lot of opioid users and drug users, so it actually does turn out to be quite a large number, and we're moving in the right direction, which is great. I just wanted to close this presentation with some conclusions and takeaways and clarify a few things. First, opioid dependence and addiction are most appropriately understood as chronic medical disorders like hypertension, schizophrenia, and diabetes. The mesolimbic reward system appears to be central to the development of the direct clinical consequences of chronic opioid abuse. This includes tolerance, dependence, and addiction as well. Next, other brain areas and neurochemicals, including cortisol, also are relevant to dependence and relapse. And finally, pharmacological interventions for opioid addiction are actually highly effective. However, given the complex biological, psychological, and social aspects of the disease, they must be accompanied by the appropriate psychosocial treatments as well. So yeah, I appreciate everybody for listening. This whole conversation obviously was sparked in class when we discussed drugs, and I'm glad I had the opportunity to dig a little bit deeper with this final project into opioids specifically, and I hope you guys learn something as well. I sure did, researching all of this stuff. It was a great year, everybody, and thanks for listening. Appreciate it. Bye.